This is one of the most critical modules because we are going to talk about what a pain team actually does and how they do it, focusing on the physical therapist and psychologist. We would like to learn what strategies each of them uses to help the patient move forward from their typically biopharmacologic understanding they bring to the team initially to a biobehavioral understanding that will help them to grow, progress, and eventually get to a point where their pain syndrome is no longer so daunting in their life.
Thank you, Tom, for that introduction. So, Elizabeth, I have a question for you, because obviously you see patients with acute pain that come for physical therapy, and then you have the patients with chronic pain. What different strategies do you use in each group?
So in those with acute pain, as I mentioned before, we do assess them for risk factors for developing persistent pain. So we still may have to address some of the things that I'm going to talk about for those with chronic pain. But we need to figure out the reasons that that pain has persisted. And so that takes a look at their entire pain experience and the experience or the environment in which their initial mechanism of injury happened. Although there's less emphasis on a pathoanatomical diagnosis from that time, it's what was going on in their life around that time. And did they develop a fear of any movements or activities at that time? And then did those persist into avoidance issues? And then we also assess for their beliefs about why their pain is happening and why it has persisted for this long. So those are particular things that we'll take a look at for those in chronic pain.
And then for the two of you, can you talk a little bit about validation and normalization? How do you apply that when you see patients with chronic pain?
Well, honestly, normalization and validation of the patient's experience, I think, is the task for all the providers. Because we don't expect people to come to us with an understanding of what the normal accompaniments to pain might be. And so to help put their pain and their pain experience in the context that we understand, I think is helpful. So it's helpful to say, it's typical that you have restrictions in your function. It's typical that you have some demoralization or frustration or apprehension. It's typical that this is affecting the whole family system or your recreational activities. And all of those things, I think, are important for each profession to address as a way of helping to provide a common language of understanding, but also as a way of helping them to accept the various elements of their treatment that are ultimately going to be most helpful.
So you use the word typical, not normal. Why did you choose that word?
I think in practice, typical, normal, usual are rather interchangeable. What it represents, I think, is our attempts to help the patients that we serve understand that their reactions in all of their dimensions are not unexpected. And by virtue of not being unexpected, that doesn't mean we should be complacent about them or accept them, but it does mean that we should address each of the dimensions that contributes to the maintenance of chronic pain.
Thank you.
Jeff and Elizabeth, we are talking about this in the context of helping the patient make the transition from a biopharmacologic conceptualization of their pain, I just need drugs, I need injections, to a more biobehavioral where I have certain elements that I'm able to control and bring to bear to help me manage this pain. How would each of you utilize the items you just talked about to help the patient move forward?
So from my perspective, the normalization lays the foundation for the introduction of all the rest. So if the patients that we see understand that the experiences that they're having and the factors that we're about to address are are usual, are normal, then that allows us to introduce concepts like factors like beliefs or behavioral factors or social factors that maintain pain.
Elizabeth?
Yeah, I think that our approach would be very similar in this normalization, and that goes a long way in forming this alliance with the patient so that they're able to, fully express their beliefs to you and able to be receptive to the messages that you're going to give them going forth. And at first is meeting the patient where they are in that spectrum. If they're very entrenched in the biopharmacological approach or belief set, then we're really going to have to do a lot of work to build that alliance so that they're able to trust us and just move those beliefs a little bit. If they're wavering, then it's very easy with education to move them along that spectrum. They just don't know, but they think, I don't know, but I think that this may be a big contributor to my problem. And then it comes down to education about those pain beliefs and everyday life examples about how that structural problem doesn't really say everything about your pain experience. Your knee hurts a lot more today, yet your degeneration is exactly the same as it was yesterday, the same as it likely is going to be tomorrow, yet your pain is a lot worse today. Why do you think that is?
And one of the ways that I get at that with patients is to distinguish between pain and suffering, which actually reflects neuroanatomy as well. What we do is we talk about how pain doesn't capture the whole experience, that at different times and at different points, you can suffer differently with the same intensity of pain. And we use the discussion about how even in the legal system we an award for an injury might include damages for pain and suffering. So that's part of our common language. And the patients that we see often get that and can say, there really are days when my 4 out of 10 pain is much harder for me to tolerate than other days. And that can lead to some productive discussions about beliefs, but also about the emotional components that are contributing to pain as a whole experience.
And Elizabeth, I think that the next question is more for you. I see so many patients that have fear of moving, of starting to do something. How do you approach those patients? How do you do it?
Well, uncovering that there is fear associated with that movement is a skill set in itself.
I was going to say, I don't think the patients recognize that. I'm hurting too much, I'm not going to do it.
Sure, and sometimes it's really easy to figure out, well, no, we're assessing range of motion, and I really don't want to lean backwards at all. That's going to cause my pain to be unbearable. And then just questioning further, well, what do you feel like is going to happen if you do that motion or if you exacerbate your pain? And that uncovers a lot, a lot of things. Well, I think that I'm going to push my disc out into the spinal cord, and I'm not going to be able to walk anymore. Because the MRI tech told me that if I move the wrong way, that I'm going to lose bowel and bladder function. And so those things that part of that patient's pain experience, then we've got to go back and address those things. So kind of getting to the root of the fear is sometimes helpful. And sometimes, and then we can retrain the nervous system to move in that direction in a less threatening way. And sometimes that's manipulating gravity, so perhaps we have them supine or hook lying and then work into extension or various things like that. So there are things that we can do to lower that movement down on their threat scale so that we're not triggering the nervous system in the pain experience.
Interesting.
And our accompanying process, driven by what we hear from the physical therapist, might be to begin to articulate catastrophic thinking and identify it as such, and help patients understand that by thinking the worst possible consequences, they're actually amplifying their pain and restricting their function more than it needs to be. And what are some alternatives to thinking about things in such a catastrophic way? What if the sentence that begins, what if I push my disc into my spinal cord and don't have any bladder function any longer, is replaced with, yes, but what if by virtue of doing these exercises I regain function at no risk to myself, and frankly, with the prospect of a much more functional life?
You know, the answer I get quite often is, okay, either I went to the physical therapist or I exercised like you told me, and then I was so miserable that I was miserable for 2 weeks. And my answer is pacing, but I would like to know what is your comment.
I like pacing, but also I use that as an example to come back to the patient's beliefs and why do you think it's worse after doing this activity this day when however long ago you did this same activity and you didn't have the same pain experience? And so to have them reflect on what may be different about that may help them make that connection between their thought process, their emotions, their stress level. Well, I only slept 2 hours last night. That was the difference.
Totally.
And we all know the horrible things that come from sleep deprivation. But you know, if we can help them make those connections themselves, then I mean, I feel like we've really won that battle over.
Absolutely, I couldn't agree more. I think what we try to do is create conditions that facilitate patients developing their own sense of insight. So much more effective than our trying to simply educate them and tell them what to expect. If they reach that conclusion themselves, then that's much more effective.
And if I could just 1 second speak to our traditionally trained physical therapists may take that information and say that, okay, well, we overdid it. I need you to just go lie down. Let's put some heat on it, and then we're going to continue your exercises. But that's, and when we talk about being pain informed, that's really despairing information if we want them to adapt really active coping strategies. And so that is just really common to hear in the physical therapy world. Okay, well, you overdid it. Let's just go lie down. Let's get your pain down for today. Let me do some manual therapy to help get your pain down. And not that I'm saying manual therapy is a bad thing or exercise in itself for those reasons, but helping the patient develop active coping strategies at that moment can be just wildly invaluable.
And I think that what I see the most is they may not even communicate to the physical therapist that, oh my gosh, I went to that session, it hurt so much. They come and tell me. And then I say, well, you need to go back and you need to call them and see what the physical therapist wants to do at that point. It's like almost there, okay, I hurt, that's it, I'm not going back.
So I think, Elizabeth, what you've just said is so important because you raised the issue of active coping strategies. And often we think that if there's an opportunity to introduce an active as opposed to a passive coping modality, we provide more of benefit to the patients. So if we can give them, if we can use massage, that may be fine. If they can learn relaxation strategies themselves, then that gives them yet another tool to help them to take more control of their situation. So the idea of using that as an opportunity for introducing an active strategy, I think, is really important.
I think we've had a very powerful discussion in the sense that this really demonstrates in a practical way how the team operates. So while Elizabeth is dealing with the practical side of fear and avoidance, the psychologist is dealing with the cognitive side of catastrophization, which are really two sides of the same coin. And I also really liked how Elizabeth pointed to the practicalities of the physical therapy visits. How does a physical therapy visits look like, pain informed, pain uninformed, and how that impacts the patient differently? I'm just wondering if you could also take us in that same direction as far as the pain informed, pain uninformed psychology visits regarding, say, catastrophization or any other piece where the psychologist would pick up on the communication from the physical therapist. Oh, I need to work on this specifically.
if let's assume that there's appropriate communication that's at the center of
Right.
all of this, so that the physical therapist and I may have had a conversation about this, then what I would attempt to do would be to not only talk about this in a pain catastrophization way and help them understand that that kind of cognitive set may be impeding their progress, but we would also talk about the notion that the best strategy for getting through anxiety is exposure to those
Right.
elements that give rise to restriction in behavior and restriction in activity, as a way of getting at the fear components and the anxiety components. So we would riff in our own worlds of what each other is doing, I think, in ways that are likely to be more helpful when they're two different voices saying similar and compatible things. And I
Right.
would be taking it in the direction really of cognitive and behavior change.
And would you advise Elizabeth, for example, to point, what you just said assumes the patient understands that this is anxiety, which they may or may not. They may view it as pain.
Yes.
Might you advise Elizabeth in some way while she's sort of on the floor in the real world with the patient in some way to bring that out so that the patient is able to then take...
That's
you
an
know,
excellent point. I think that our patients often, the final common pathway to most of their distress is pain. They talk about pain, which is a stand-in, as far as I'm concerned, not only for what we think of as nociception, but also for the fear and the demoralization and the frustration
And the anxiety.
and the anxiety that accompanies that pain. If we can get our patients to begin to expand their language and identify each of those elements, then that creates a pathway for them to begin to take control of each of those elements as well.
So Jeff and Elizabeth, do you usually give homework to the patients, either when you see them for physical therapy or for cognitive behavioral therapy? And what is the purpose?
In my case, I almost always use homework. If for nothing else, then the typical hour that we have a week represents such a small chunk of time that we have much more power for the patients to be active in their own recovery if they're doing homework and paying attention to factors that we'd like them to highlight. So depending upon where they are in their readiness to accept our reconceptualized behavioral approach to pain, we'll give homework that is really designed to both have the patients more active and engaged on their own behalf, and to set the stage for their development of insight into various factors that contribute to either the exacerbation or the alleviation of pain. So, for example, in a patient who is not very willing to accept our more multifactorial approach, I might ask them to graph their pain on a daily basis and then pay attention to the factors that contribute to its getting worse or getting better. And they find that helpful, and it helps them to gain some greater insight, and it reinforces some of the concepts we're trying to introduce.
Yes, so as physical therapists, I think we would be banned from the profession if we didn't give some home exercise. And it takes various forms. If we're talking about that patient that is high fear, then we're going to talk about very small movements in a non-threatening situation. We may decrease external stimulus at that point, like a quiet, dark room. And then moving on, the ultimate goal is to get everyone on some sort of aerobic type of exercise. The evidence out there for pain modulation from aerobic exercise is outstanding. So we ultimately want to get that person there. What we find in this population is that we need to do more than prescribe that exercise with this progression. We need to meet the patient where they are. What is an acceptable amount of exercise for us to start with? And what is an acceptable amount for you to increase each week or a certain time frame? And now, what are you going to do when this happens in your life and you become too busy, or your pain is high that day? How are you going to keep yourself accountable to doing this exercise or this amount of walking when things are flared up? You know, or what is going to be your coping strategy for that? So we have to go into a lot of those questions down the road and exploring some of those barriers before they've had a chance to derail the patient.
So is aiming for aerobic activity a characteristic of pain-informed physical therapy, or is that something that everybody aims at doing in the physical therapy world?
I'd say there are many conditions that we're less concerned about aerobic exercise for those people. It is a hallmark of treating those with chronic pain.
And that's what we prescribe as doctors, but it's so good to hear that that matches what a pain-informed physical therapist is also prescribing.
Yeah, and as I say, it's really easy to say that and give it to them, and it's another thing to help convince them that they feel like it's needed and that it's a priority in their life.
Totally.
Do you spend time trying to conceptualize with patients why this is important, why you're assigning something in particular? Do you try to create those links?
Yeah, so I like to draw multiple webs back to their primary goal and what we've discussed as part of their pain mechanism. So I'll come back and use some analogies on why maybe how their pain experience has developed or why it's being perpetuated. And so we'll come back and tie the aerobic exercise or exercise in general to decreasing whatever analogy we've used as maybe the threatening pain lion. In some ways that exercise helps turn that lion into a little cub. So we use those, and then that speaks to their overall goal. Then we'll take that 30,000 foot view again, and this relates back to your overall goals of whatever XYZ.
I think that active conceptualizing is so important, giving the patients that we see a reason for the things that we do, a mechanistic understanding. I'm sure it helps with adherence to the regimens that you recommend that they do at home.
Oh, absolutely.
Yeah, good.
So this was an excellent discussion. I would like to give as quick and brief a summary as I'm able. So what we learned today is that the strategies used by the physical therapist and the psychologist are very complementary to one another. The psychologist assesses cognitive issues and behavioral issues through cognitive behavioral therapy, while the physical therapist assesses elements of movements, anxiety, and fear that may hinder the patient's progress. And specifically assesses maladaptive beliefs. For example, every time I bend my back, I am going to damage my disc, and attempts to correct those so the patient can make progress. We learned also today that it's critical that the two work very closely together so that the elements that are addressed at a cognitive level are also addressed at a physical and behavioral level.